Yeah, so welcome everybody to today's ERKNet webinar in nephrology and rare kidney diseases, organized together with the European Renal Association, specifically the working group Genes and Kidney. I will be one of the moderators. My name is Roman Müller. I'm a nephrologist in Cologne, Germany, with a specific interest in hereditary kidney diseases and rare kidney diseases. And I have the pleasure to do this today together with Jean-Baptiste Latouf. Jean-Baptiste, you quickly want to introduce yourself?
Yes, so I'm a uro-oncologist with an interest also in hereditary kidney diseases. I trained at NIH and I have a good population of such conditions. So it'll be my pleasure to co-moderate with Roman and answer your questions.
Wonderful. So you already see by the choice of moderators that this is an interdisciplinary topic, and we could probably have 6 to 8 moderators if we wanted to fully reflect that, but that's something we're going to learn from Jan's presentation as well. As a speaker today, we have Jan Degenhardt, who is a physician in Cologne at the University Hospital and coordinates the outpatient unit on rare kidney tumors, hereditary kidney tumor syndromes, and one of those is hereditary leiomyomatosis and renal cell carcinoma, which, as you're going to see, is a very special topic with special needs and that are not fully reflected always in clinical care yet. So Jan, looking forward very much to your presentation. Before we start, one quick remark. This is a webinar, so all participants apart from the moderators and the speaker are muted, but we'd be happy to discuss your questions. Please enter them in the question session and we'll either answer them in a written form or interrupt Jan or address them at the end of the presentation. Wonderful. So Jan, looking forward to what you're going to tell us today.
Thank you, Roman, for the introduction. So I'm going to talk about HLRCC syndrome. We're going to start out with a short primer on renal cell cancer, on HLRCC and the canonical manifestations, the pattern mechanisms underlying the tumor formation, and in the end, the specific treatment and surveillance strategies pertaining to HLRCC, since it's quite different than other hereditary kidney cancer syndromes that you might encounter as a nephrologist. To start out, I have one quick poll question for the audience, whether you encounter any patients with hereditary kidney tumor syndromes, mostly probably tuberous sclerosis, von Hippel-Lindau, or Burkitt-Dubé syndrome in your practice. The poll should open shortly in GoTo. And I will come back to the results at a later point and start with the basics for renal cell cancer. Renal cell cancer is the 6th most common form of cancer with a lifetime prevalence across the general population of 2.2%. And of course, there are some environmental and lifestyle risk factors, mostly in line with other tumors like smoking or obesity, but also genetic components. And while only 3% of RCC patients have a family history of renal cell cancer in their family, up to 16% harbor some pathogenic germline mutations in cancer susceptibility genes predisposing to either specifically renal cancer or cancer in general. And if we compare cohorts of hereditary renal cell cancer syndromes to cohorts of sporadic kidney cancer, we see quite a difference in the age distribution of age at diagnosis, with the hereditary cohorts having a peak around 40 years of age, and the sporadic tumors more around 60 to 70 years of age. And this gap between hereditary and sporadic kidney cancer raises some challenges also for us nephrologists, since these people have increased exposure to the risk of chronic kidney disease complications after they have received partial or complete nephrectomy. They are, of course, also at increased risk for recurrence of kidney tumors if they only undergo partial nephrectomy, and they often harbor interdisciplinary or need interdisciplinary care because of multi-organ syndromes. And I think internal medicine is predisposed to caring for this patient from a more general perspective. And of course, as nephrologists, after complete bilateral nephrectomy, in case of no other life-limiting tumors, we have probably good candidates for transplantation. And this should also guide us as nephrologists when seeing these patients. Obviously, you all know that in tumor biology, we have made a huge stride forwards to characterizing the genetic and metabolic profiles of various tumors. And here's a very cluttered table exhibiting the various genetic alterations that can be observed in sporadic renal cell cancer. And in some cases, these genetic mutations or alterations are distinguish some entities from others. For example, in cases such as the ELOC mutated renal cell carcinoma or FH deficient renal cell carcinoma. In other cases, we have high prevalence, for example, of VHL mutations in clear cell renal cell carcinoma. And if you have a look at the general table, you will encounter many known genes that you might maybe more associate with some classical tumor predisposition syndromes when they occur as germline mutations. Here's a short list: VHL, BAP1, more recent discovery, FH, of course, MET for the hereditary papillary renal cell carcinoma, and of course some mutations like TSC1 and 2 or folliculin. Renal cell cancer can also be looked from the other side of the lens. There was a study in the UK done where sporadic, or up to that point, cases which were deemed sporadic underwent whole exome sequencing, and in these 1,400 cases, a lot of patients showed germline mutations in cancer susceptibility genes. And what's very interesting here is that, for example, CHEK2, cancer susceptibility genes for renal cell cancer, occurred in a large number of patients, which is not yet, I think, in our minds as clinicians as predisposing for renal cell cancer syndromes. And I think this illustrates greatly the large knowledge gap that we have in hereditary renal cell cancer syndromes. What's the clinical challenge for us? Well, we have some syndromes like, for example, VHL or follicular or Berthold-Dubé syndrome or tuberous sclerosis, which have a very high penetrance of extrarenal manifestations, very characteristic onset and early onset of symptoms, and there we can get to a clinical diagnosis more easily than in some other cases where only renal cell cancer might be part of the cancer susceptibility gene, cancer susceptibility syndrome. And in the case of FH mutations leading to HLRCC, we're talking about the most aggressive form of renal cell cancer, so the correct identification and care for these patients is especially important. And of course, these are not all the same entities, and as such, surveillance and treatment strategies differ between them. So I'm having a look at the first poll, which I'm not seeing yet.
Can you see?
Yes, I can. If you can't see it, so we have 100% saying yes. We do encounter patients with hereditary kidney tumor syndrome. So we have a group of people listening that are aware of this topic. However, I also have to say 54% voted only. So we're not sure whether only those voted that actually do see patients as well.
Okay, perfect. So the next question, maybe it's also 100%, which would be quite exciting. So have you encountered a patient with HLRCC in your practice? We'll also go back later when you have a time to answer this. Just to get everybody up to speed, HLRCC as a tumor predisposition syndrome is caused by mutations in the gene encoding for fumarate hydratase. and people are at a predisposition to develop skin leiomyomas and uterine fibroids, which are also leiomyomas from a histopathological point of view, and a special type of renal cell cancer deemed FH deficient renal cancer. Looking at these patients, we see a higher frequency of renal cysts in approximately 40% of patients, and there are some rare occurrences of paraganglioma and pheochromocytoma in these patients. On the right, you see a fish image showing the hybridization of the mutation site on chromosome 1 of FH. Historically, the first description of HLRCC reaches some 50 years back, was done by a physician and dermatologist named Reed, and he described two families who exposed or exhibited cutaneous and uterine leiomyomas. And one girl in this cohort had a renal cell cancer at the age of 20, which turned out to be a renal cell carcinoma upon resection. In the black and white images on the right, we see the cutaneous leiomyomas on the top, which exhibit a reddish to brownish color if you see them live. You see the nephrectomy preparate with a arrow-marked tumor invading from the cortex, and you see the bizarre histomorphology of the uterine leiomyomas in the 20-year-old patient. This is the first description of all typical HLRCC manifestations, but since only one patient had a renal cell cancer, it was not connected as part of the clinical syndrome. Some close to 30 years later, renal cell cancer was connected to the clinical syndrome, mostly by connecting it to uterine fibroids by a Finnish researcher. And they were also able to map the mutation to chromosome 1, and they coined the HLRCC tumor predisposition syndrome. 2002, the FH gene was identified on chromosome 1 for HLRCC. And since then, we have made huge advances in understanding the underlying metabolic and oncogenic changes arising from those FH mutations. What was true in 2002 and is also true today that we cannot really link the genotypes to phenotypes, for example, identifying which patients only get leiomyomas, which patients also get renal cell cancer. How frequent is HLRCC? There are around 350 families published internationally, and around I think 1,000 patients treated at the largest center for HLRCC in the US. We recently did a poll across the European networks, Australia and the US, and identified some 1,500 to 2,000 patients with HLRCC, albeit there might be some overlap, but in general, it's to be suspected that HLRCC is an underdiagnosed condition. Another way to approach the frequency of HLRCC is to look at the predisposing mutations. And Brian Schruck from Los Angeles did some study involving exome sequencing data, and they discovered a frequency of 1 to 1,000 for F8 variants of concern. They further stratified these variants into the likelihood of causing HLRCC and found the lifetime renal cell cancer prevalence in these groups between 1.7 and 5.8%. Of course, being close to the lifetime prevalence of renal cell cancer in some cases of the general population of around 2% that I earlier mentioned. So HLRCC is still a quite rare disease, but maybe we can make some advances in the future in identifying predisposing F8 mutations or even predicting the biological impact of these specific mutations. So the aforementioned researcher Lornanen already observed in the renal cell cancer samples he obtained from his patients that all tumors were homozygous for FH loss. And looking at the FH gene and enzyme, it's coding for fumarase and lyase located on chromosome 1. It's an autosomal dominant mode of inheritance for HLRCC, but the patients do not exhibit any symptoms besides tumor formation. However, for a quick side note, there's also the possibility of homozygous FH mutations. This leads to a condition coined fumaric aciduria or complete FH deficiency, and is associated with a severe encephalopathy, delayed development, often early death or lifelong dependence on care. There are very, very few cases reported, and a large cluster of these cases stems from a Mormon community in Arizona. These are not characterized in a very extensive way, so I'm not going to further go into homozygous FH mutations, germline FH mutations, that is. Loss of heterozygosity, however, in the somatic setting is what causes the tumor formation. We do not see metabolic alterations in cells only harboring the germline heterozygous mutation in FH, but upon loss of heterozygosity, people develop skin leiomyomas, uterine fibroids, and renal cell cancer. However, the cause of this loss of heterozygosity are completely unknown. And this is also a huge interest of research right now. To go just a little bit into the underlying changes on the metabolic level, FH, fumarate hydratase, is an enzyme of the Krebs cycle or tricarboxylic acid cycle, and effectively in the setting of loss of FH activity leads to a truncation of this cycle. The cycle ceases to be a cycle, and we have, of course, the accumulation of fumarate, and we have the impediment of mitochondrial respiration on the one hand through inhibition of the electron transport chain, and on the other hand, the accumulation of fumarate inhibits succinate dehydrogenase. This, in turn, leads to an accumulation of succinyl-CoA. To compensate for this impediment of oxidative phosphorylation, other pathways have to generate energy for the cell. This is achieved in one part by anaerobic glycolysis with lactate production, on the other hand by the pentose phosphate pathway. This is in general coined glycolytic flux or increasing glycolytic flux. On the other hand, since the GCA cycle is truncated, these cells also increase their fatty acid synthesis, and this is achieved through increased glutamine uptake, which retrogradely is metabolized to citrate for fatty acid synthesis in reductive carboxylation. So this is only some part of the metabolic changes in the setting of FH activity loss. To combat this fumarate toxicity, there are some possibilities or strategies to eliminate fumarate. On the one hand, fumarate can permeate into the nucleus or into the cytoplasm and extracellularly. On the other hand, fumarate can be metabolized, for example, in the urea cycle through reversal of the argininosuccinate lyase. This consumes arginine and conjugates arginine fumarate to argininosuccinate, and in the effect, the cells are completely dependent on a constant uptake of arginine and are not viable if this arginine is, for example, removed from the cell culture media in some experiments. Another way to eliminate fumarate is through the purine nucleotide cycle. Also through reversal of the adenylosuccinate lyase, and this impacts the ability of the cell to produce purine nucleotides, making cells reliant on the purine salvage pathway. This is what results from these metabolic alterations. In the end, you can see a plethora of pro-oncogenic pathways. I think if we go into detail in each of these pathways and how fumarate accumulation might induce these, this webinar is over already. So it's probably best to note that we see some signaling pathways that are also present in other renal cell cancer or renal tumor syndromes. For example, increased AKT signaling, reduced AMPK signaling, and of course, inhibition of the prolyl hydroxylases, leading to the state of pseudo-hypoxia, meaning increased HIF signaling in the setting of normoxia. Downstream of this, we see, for example, TGF or VEGF signaling, leading to angiogenesis proliferation as factors of tumor growth. While these pro-oncogenic pathways are not completely exclusive to HLRCC, there's one thing that is exclusive to HLRCC, and that is a process called protein succination. This resides from the conjugation of or reaction of fumarate and cysteine to 2-succinylcysteine, effectively being a post-translational modification of cysteine. And this can be present in regular cysteine amino acid, can result in succinated glutathione or in other thiol group carrying proteins. This post-translational modification can also have a plethora of downstream effects, also probably exceeding the scope of this webinar, and not being of clinical relevance right now. Where succination is quite relevant is in the staining and diagnosis of HLRCC. We see here a section 1 or A to D mouse tissue, on the one hand stained with anti-FH antibodies. We see a strong anti-FH signal in a healthy kidney tissue, section A, and we see in the mouse model in section C some sections with positive FH staining, but also some cysts, which correspond to the murine phenotype in FH deficiency, where the cyst walls are FH negative. To compare it with section B, it's the same section as in A, where we see a positive FH stain, we see no anti-2SC staining. In section C and D, it's quite impressive how the sections of the cyst wall who show some activity of FH or some staining for FH show less staining for 2SC, and the rest of the cyst wall, which is FH deficient in section C, shows a strong signal of 2SC. The 2SC is the most sensitive marker in immunohistochemistry for the loss of FH function. And this staining is also conducted in kidney or uterine tissue of HLRCC patients where the FH deficient tumors or uterine fibroids show a strong signal for 2SC. Succination is not only interesting in the setting of histopathologic diagnosis, but two groups were able to show that the succinated metabolites resulting, for example, from FH-deficient renal cell cancer get secreted into the bloodstream and can be measured as blood metabolites. This is not yet clinical routine, but in the future, maybe there will be some form of screening for HLRCC or HLRCC-associated renal cancer by measuring these succinated metabolites, such as succinated cysteine. Before we continue into the clinical part or more clinical part, I want to clear up some conceptions about terminology. HLRCC literature is not completely unanimous when coining the disease. FH deficiency tumor predisposition syndrome is probably the scientifically accurate description, just describing the risk to develop the manifestations of HLRCC from a germline mutation in one FH allele, while HLRCC syndrome is, of course, the uterine fibroids, leiomyomas, and renal cell cancer that people can develop together, of course, with a pathogenic FH mutation. And it's important to know that FH-deficient renal cell carcinoma can also occur sporadically without any germline FH mutations. These FH-deficient renal cell cancers also exhibit a loss of heterozygosity, but no germline mutation is present there. This is just a short visualization of these terms, showing the FH tumor predisposition some patients with leiomyomas and this predisposition, some people with the full HLRCC syndrome with FH deficient renal cancer, leiomyomas and the mutation, and some patients only having FH deficient renal cell cancer without any germline mutation. To get into the various organ manifestations, we have on the one hand the leiomyomas. These are relatively highly prevalent manifestation of HLRCC. They are generally benign from a histopathologic point of view, but can inhibit some borderline features such as bizarre nuclei, and can in some few cases also dedifferentiate into leiomyosarcomas. Nevertheless, they are not routinely excised from an oncologic point of view. The onset for the cutaneous leiomyomas is a little bit earlier than for the uterine leiomyomas, around age 20, and the uterine leiomyomas around age 20 to 30. The cutaneous leiomyomas also increase in size, number, and prevalence with age, and since they have often connection with or derived from the musculus erector pili, so the muscles who raise the attached hairs to the skin, they are very painful, especially if exposed to cold temperatures. These cutaneous leiomyomas pose a huge burden on the patients. We often tend to ignore the relevance of these painful and often aesthetically unpleasant manifestations. But many patients, especially if they are not suffering from other manifestations like renal cell cancer, see these leiomyomas as impacting their quality of life in a huge way. Excision is always possible in the setting of limited presence of leiomyomas, and can also lead to diagnosis of HLRCC due to presence of specific pathologic features and FH deficiency of these leiomyomas. On the other hand, there are non-surgical treatment options like cryotherapy, anesthetics, various topical treatments like cyclosporine or laser or ultrasound ablation. Uterine leiomyomas are also a manifestation of HLRCC, and there we see a difference between the sporadic occurring leiomyomas, which are also not uncommon, but in HLRCC, these leiomyomas occur much earlier, at an age around 33 years versus 45 years in the general population, and often in multiples and very large size. On the right side, you see an MRI image of a young patient with a few very large uterine fibroids. There's also no standardized treatment approach and nothing that can causatively address the underlying FH deficiency of these leiomyomas. Often in early occurrence of these fibroids, family planning is not yet finished for these patients. There are, of course, hormonal and surgical treatments for leiomyomas in general, but these will have to discuss individually with the patient with the implications for family planning and possible complications. For example, if a conservative approach is chosen and fertility issues or bleeding arise from this. Hysterectomy is often required, and even a diagnostic feature of HLRCC is, of course, a huge impact on the reproductive health of the affected women. So since we talked about leiomyomas, we can approach the diagnostic criteria of HLRCC. These were lastly updated in 2014 and consist of A, histologically confirmed multiple cutaneous piloleiomyomas, which is the histologic subtypes we see in HLRCC, or at least two of the following manifestations, which are surgical treatment for symptomatic uterine leiomyomas before age 40, or HLRCC-specific renal cell cancer pathology. There we have seen a recent update. Type 2 papillary renal cell cancer has been known for more than 15 years and was lastly mentioned in the 2016 WHO classification. and refers to a distinct type of histopathology that we are going to discuss later. However, FH-deficient renal cell cancer has been recently updated in the 2022 WHO classification, refers to immunohistochemistry staining of these tumors. So there's already some room for updating this diagnostic criteria. And there are other renal tumors, such as the collecting duct carcinoma, that are also strongly associated with HLRCC and have been proposed as separate diagnostic criteria. If a patient himself or herself has not yet these manifestations, it suffices if only one of these criteria is present, but a first-degree family member fulfills the full criteria. To get into the HLRCC associated renal cell cancer, there are a few important facts to know. The prevalence is much less than the prevalence of leiomyomas. For leiomyomas or uterine fibroids, the cumulative prevalence around lifetime borders 100% for the cutaneous leiomyomas and is around 80 to 90% for the uterine fibroids in female patients. However, for renal cell cancer, this is only true in 50% of the patients who develop renal cell cancer in their lifetime. There's a huge gap between the reported RCC prevalence in different cohorts, but 15% is around the middle in the largest cohort. And sadly, this renal cell cancer is the most aggressive form of renal cell cancer that we know of, with around 65 to 85% presenting already at a metastatic stage, often with bilateral tumors and early invasive growth of these tumors, with an age at diagnosis around 40 years. There are some select case reports with the renal cell cancer in the setting of HLRCC occurring as early as 7 years. The age distribution is shown on the right side. It mostly matches the age distribution of the hereditary kidney cancer cohort I showed on an earlier slide. And this means that other forms of hereditary kidney cancer might pose differential diagnosis. It's important in these patients to assess the extrarenal manifestations and the RCC pathology to really arrive at the right course of action and diagnostic tests. What do we look for in the RCC pathology? These are some slides from our pathology in Cologne. Section A and B show some pathologic features that were deemed characteristic for type 2 papillary renal cell cancer. In section A, you see a papillary growth type. In section B, you see a mixed solid type. It's quite characteristically for HLRCC that the tumors have admixed histologic features and are not singly one type of tumor. And what is pathognomic for type 2 renal cell cancer or FH-deficient renal cell cancer is these eosinophilic or orangophilic nucleoli that you see in the enlargement from section C. These inclusion bodies are only seen in type 2 papillary renal cell cancer. Section D and E are FH stainings. On the one hand, section D is healthy kidney tissue, which is strong positivity of the tubuli for fumarate hydratase aminohisto IHC staining. The glomeruli are slightly positive in the mesangial cells. Section E is a section through HLRCC associated renal cell cancer, where we see no FH positivity in the staining, except for some vascular signals in between the tumor cells. There are, however, some caveats to the histopathologic diagnosis of FH deficient or HLRCC associated renal cell cancer. That is that the FH loss on immunohistochemistry is not fully sensitive for real FH activity loss. And there, the 2SC immunohistochemistry comes in and can provide the remaining sensitivity to correctly diagnose FH deficient renal cell cancer. The availability of the 2SC stain is not as wide as for the FH stain. So in some borderline cases, it might be very, very wise to contact a center which can do the 2SC staining, or some pathologist who can do the staining to either confirm or rule out diagnosis of FH deficient renal cell cancer. And of course, there are some rare occurrences of non-papillary renal tumors in HLRCC or some mixed type tumors where there's a sampling error, for example, incorrectly identifying these FH deficiency associated tumors. How can we continue from a patient that has a renal cell cancer or presents to us with an unclear tumor syndrome? For testing for hereditary kidney cancer syndromes, there are some guidelines which are not unified across US, Europe. I know we have some guidelines in Germany for certification of oncologic centers to test for hereditary cancer syndromes, and in other countries some slight differences exist, but they all take into account the age and localization and pathology of the renal cell cancer diagnosis, extrarenal manifestations, and the family history of the patients. There we have a wide spectrum of diseases. We have in red VHL, TSC, or Bertok-Dubé, for example, who show quite characteristic phenotype and have a high penetrance of these extrarenal manifestations, aiding our clinical diagnosis. We have some intermediary cases like Cowden syndrome, paraganglioma, pheochromocytoma syndrome, and we have also some more common hereditary kidney cancer syndromes such as chromosome 3 translocations or HLRCC or CHEK2 associated renal cell cancer, where we don't know about typical extrarenal manifestations. In general, we expect 1 in 20 renal cell cancers that might be linked to hereditary kidney cancer syndromes. And if we compare this baseline figure to other hereditary cancer syndromes, for example, to BRCA mutations predisposing to breast or ovarian cancer, we can maybe benchmark our diagnostic efforts. For breast cancer and ovarian cancer, for example, there exist standardized questionnaires to indicate genetic testing in some patients, and these are part of the standard of care of these cancer patients. And for benchmarking, they want a number of 10% positive diagnostic yield for referred patients. And if we look at 1 in 20 renal cell cancers that might be linked to hereditary kidney cancer syndromes in exome studies right now, I think we can achieve a lot of work into standardizing questionnaires for referring patients to genetic testing. I think 10% should be quite achievable to reach. So people with confirmed HLRCC need continued surveillance. This consists of all 3 typical organ manifestations. For skin, yearly dermatologic assessment at age 8 is recommended. For uterine manifestations, OBGYN follow-up with ultrasound starting at age 21 is also yearly recommended. However, for the kidney, the yearly MRI recommendation differs from other hereditary kidney cancer syndromes with the start of the first MRI at an age 8 to 10. This is followed up by ultrasound starting at age 12 and being repeated biannual, and from age 18, a yearly MRI of the abdomen is recommended for surveillance. Upon detection of a HLRCC-associated renal cell cancer, there are various treatment strategies. For limited disease or treatable disease, it's always early surgical treatment with a margin resection that's recommended. Nephroid-sparing strategies are, of course, to be preferred whenever a complete tumor removal is possible. This is to be contrasted with other forms of hereditary kidney cancer, for example, HLRCC or VHL, where there are some active surveillance rules pertaining to tumor size. Renal cysts are more frequently present in HLRCC, and the problem there is that even some solid component can present renal cancer. There are some case reports about patients with a seemingly uncomplicated cyst or only some septated cyst developing metastatic RCC disease stemming from that cyst in a short time span. So the Boston classification is not helpful in guiding the surveillance of cysts with solid components in HLRCC. There, mostly early resection of suspect cysts is indicated. I earlier mentioned that around 2/3 of patients already present in the metastatic setting. So there's a huge point to address what options exist for advanced renal cell cancer. Earlier, I showed the various pro-oncogenic pathways involved in the HLRCC development of HLRCC-associated tumors, and these are relatively recent developments, and there are already some phase 2 trials underway. These look mostly at VEGFR or EGFR inhibition, and for example, PD-L1 inhibition with atezolizumab or HIF inhibition with vardetanib or talazoparib. I want to go more into detail in one trial that's conducted in the US, which is a phase 2 study of bevacizumab and erlotinib, so a VEGF and EGFR receptor inhibition for people with advanced HLRCC-associated renal cancer, and they did see an effect or a comparative effect in the HLRCC cohort with increased median progression-free survival by 50% in the HLRCC cohort. So to conclude, I want to give some key points regarding HLRCC. So HLRCC is caused by germinal FH mutations, and we see characteristic uterine and cutaneous leiomyomas, and of course, the most aggressive form of renal cell cancer. These FH mutations cause the accumulation of fumarate, and this alters the cell metabolism, affects tumor regenesis, and is therefore referred to as an oncometabolite. Fumarate leads to protein succination, and this plays, on the one hand, a role in tumor regenesis, and on the other hand, can be a valuable diagnostic target. The metabolic features of HLRCC could and can be exploited as disease markers and therapeutic targets. And we see distinct pathologic features. The recognition of extrarenal manifestations and family history can facilitate our early diagnosis of HLRCC before the occurrence of renal cell cancer. The early resection after detection is the treatment of choice for limited disease in HLRCC and the associated solid kidney tumors. And we have to change our strategy regarding active surveillance in the setting of HLRCC. So suspected HLRCC favors genetic testing because of the huge implications of the detection and surveillance for renal cell cancer with the aggressive behavior. And lastly, we are in the process of developing HLRCC tapered, albeit not specific treatment approaches, and are seeing promising results in phase 2 trials. So I'm right now remembering the last poll question, and before I conclude my talk, I would like to hear the results from Roman, but otherwise, thank you for your time.
I just brought them up again. I guess the attendees can see them. You might not be able to see them again. So this time it's less clear. It's actually 63% saying they have not seen a patient with HLRCC in clinical practice yet. 38% say yes, they have, and 50% voted.
Okay. So there was still hopefully some new information in the webinar. Not everybody is routinely seeing these patients. Perfect. So again, thank you all for your attention and your time, and let's continue on with the discussion.
Thank you very much, Jan, for this nice presentation and very complete overview. There are no questions in the question section right now, so please enter if you have anything you'd like to know and learn and would like to be discussed among us here today. Otherwise, we'd maybe start with a couple of questions for you, Jan, and start the discussion. Jean-Baptiste, you want to start, or should I go ahead?
Yes, Jan, thank you very much for this excellent presentation. Covers the topics really well. We know that for VHL, there's a phenotype-genotype correlation with the mutation type and the syndromic presentation. Do you know, can you comment on if there's any for HLRCC and any and he thinks the clinician should seek to have a more intense surveillance when it comes to renal cell carcinoma expression.
So to my knowledge, there's no genotype-phenotype correlation in HLRCC, and in fact, the mutations can't even be located to maybe only some exons of FH. The pathogenic mutations, they span the whole gene, and therefore we have increasingly knowledge of more and more pathogenic mutations in FH, but cannot map these mutations to a specific phenotype. It's not even inside families with the same mutation that we can see higher or lower RCC prevalence. I think the variability in the reported renal cell cancer prevalences is mostly a sampling error or sampling bias, more likely, in the various cohorts.
Thank you.
There's always a bit of a question of how many cases do you have per genotype and so on, and then rare diseases. And we've already seen, and I think that's a good take-home message today as well. While we all tend to see more and more be aware of hereditary kidney cancers and kidney cancer syndromes, HLRCC appears to be not that common yet, and that may also be a consequence of maybe not so pathognomonic features and an under detection, and that's something, Jan, I mean, you've just recently performed a large survey revealing a much larger number of patients than you'd expect if you just check Google what's the actual prevalence worldwide. So we're probably here really looking at something that needs a lot of awareness still. Now, partly awareness for this is, and you've nicely shown the key characteristics of patients in whom we should think about genetic kidney cancers, genetically defined kidney cancers, depending on age and extrarenal manifestations and so on. One point is histopathology as well, which often it doesn't exist yet when we see the patient the first time, but once we have it, we and the pathologist should be aware. Now, in the past, at least the type of the papillary RCC gave some indication, and also gave pathologists a reason to say maybe you should check. You've quickly alluded to the fact that this has changed. This classification has changed by WHO, and that we're more relying on the fumarate hydratase stains. Can you quickly say again, in a patient in whom you suspect that there could be a genetic form, but the answer is, and could be HLRCC as the cause, the answer is, because, and you quickly said that, but just because it's so important, FH is fully positive, so HLRCC is ruled out. What's your thoughts on that, and what could be the reasons for false negative finding towards the diagnosis in this setting?
So I think this is a point where the interface between the clinician and the pathologist is very important. It would, of course, be interesting on the one hand to hear what lets me think that that this patient really has HLRCC, because maybe he already fulfills the diagnostic criteria with his extrarenal manifestations. For the pathology part, some pathologists, of course, can also describe maybe the type 2 renal cell cancer that they find according to the older WHO classification. And it's just important to know that the positive FH stain is not a rule out for HLRCC. It's just that the negative FH stain is a rule in. And this positive FH stain in the setting of suspected HLRCC should then be complemented with the 2SC stain.
And that's a very, very important point, because it also is true for other tumors, not only HLRCC, but also, for example, the succinate dehydrogenase associated tumors. A lack of a finding in the actual immune histochemistry does not mean that the antigen is not affected on the enzymatic level. So it may still be fully present, even overexpressed as a feedback, but the enzymatic function is fully gone, and the enzymatic function of FH is actually, right, the reason for the formation of tumors in these cases.
Maybe I should add also that you should listen a lot to your pathologist. These tumors don't present often bilaterally or multifocally. If the pathologist has a suspicion, then you should go ahead and screen because you know it's a different beast. It's not like the other familial syndromes. So genetic testing here should be reliable on the histopathology, like you said, Roman.
Yeah, absolutely. So this interaction is really important, and we have to learn from each other there. One thing where interaction also plays a role is extrarenal manifestations, right? We probably as medical doctors, we're always a bit focused on the malignant lesions and those that we feel have the most important impact on survival, and that not necessarily may be the same things that are the key burden to most of our patients. What's your experience? Is it easy for HLRCC patients affected by HLRCC to find experts that can help them with renal is already difficult, but with the extrarenal manifestations at this time?
At this time, I think it's very difficult, and usually depends on the personal motivation of their treating specialist. Many of these lesions get first seen by outpatient clinics and then referred maybe to a specialist center of the specific histopathology suits or matches up with HLRCC. I think there's is a large need to raise the awareness, especially for the gynecologists when they see young patients with a large burden of uterine fibroids earlier than you would expect, to, on the one hand, refer these patients, and also to address some things or questions like family planning really early in their life, to not be surprised by a hysterectomy. From the view, from a limited amount of patients that I saw with HLRCC, everybody in retrospect had some extrarenal manifestation, and some patients really regret that their treating gynecologist or their treating dermatologist did not recognize the typical lesions of HLRCC. And I think if these patients get referred to us as nephrologists or to the urologist with a renal tumor, that's the latest point where all the pieces of the puzzle have to be put together to really aid these patients.
So again, it's about awareness in the field, right? And it's usually years between, especially the extrarenal manifestations and the real diagnosis. And even, and I guess we've seen those patients very often as well, even with multiple kidney tumors in the family, it's often still years until somebody pinpoints this and says, this is probably genetic and this could be HLRCC. And I think while not everybody can and should become, for that, it's too rare, an HLRCC expert, it's still important to team up and spread knowledge, but especially awareness, which is even more important, and then letting people, both patients and other stakeholders, clinicians in the field, know with whom they can get in touch, to discuss together and get some counseling on what to do and how to do this. And this is where there's still much room for improvement. One of these movements is the recently initiated HLRCC Alliance that will try to do exactly this and create an option for also patients to just get in touch and learn where might there be a physician to take care of this specific condition associated with HLRCC, and for physicians on the other hand to learn from each other. So this will be extremely important and will accompany awareness initiatives. Having said this, I see no questions in the question section. Jean-Baptiste, did you still have something you wanted to add?
I think Jan covered the subject really well. Congratulations, Jan. I'm really impressed. Thank you.
So thank you very much, Jan. Again, thank you to all of the participants. If you have questions, if you would like to do more in this field and so on, feel free to reach out at any time. I think Jan would be glad to do more of the team working that we've done over the last months. And having said this, We also want to announce that there is a bit of a summer break with the ERKNet webinars, and it'll restart in September with a webinar by Roberta Fenoglio on monoclonal gammopathy of renal significance, which is a very important topic. And then another rare disease topic, ciliopathies. And actually some of the kidney cancer syndromes may also be ciliopathies. Big topic for kidney. Maureen Stokeman from Nijmegen, from the Netherlands. So ERKNet will be happy to have you all on board then again.
Yes,
with that,
also
Jan?
from my side. Yes. Sorry. I just wanted to thank you all for this nice presentation, and I wish you a nice afternoon.
Thank you for the opportunity.
Thank you very much.
you.
Bye-bye.
Bye.
Bye.